Hi all, today we're going to go over chapter 8 in our class and look specifically at foot and toe pathologies. So kind of to start off, I want you guys to get up and walk around. Literally, get up and walk around. I know you're just sitting there. Okay, so what we're looking for when we're walking around is we're looking specifically at our gait pattern. And what that means is by looking at somebody how they walk, what their normal walk is. So, and I try and look at this with my patients when they don't necessarily know that I'm watching them. I know that sounds kind of creepy, but I'll turn around and watch them walk into the room. And hopefully we can identify some inconsistencies or alterations in their gait that can help us identify specifically what is going on with their body and within the kinetic chain. It helps us a whole lot, specifically for lower extremity. And for this photo that's out of your guys' book, we are looking at the right foot. Okay, so you can go back and sit down. I know you've already done that anyways. But when you're walking around, there's that initial contact. With that initial contact, it's basically the heel strike, or where your calcaneus is hitting the ground. When you walked through and you put more weight on it, it is going to be a loading and then a mid stance. The terminal stance is when you are swinging through on the opposite side, and then as you are dorsiflexing your foot for in the pre-swing and initial swing, you're unloading the weight bearing of that. Okay, so I know it was kind of awkward walking around. I encourage you not to go out or anything, but the next time you're at the grocery store, or my favorite place to people watch was at Disneyland, believe it or not. There's so many different gait patterns going on, and I'm just a nerd like that. So trying to look at different postures and different way people are not only standing but how they're walking is going to help you become a better clinician as we learn different aspects of that. So a little bit about the clinical anatomy of the foot and toes. There are 26 structures and there are additional sesamoid bones in there, and they are all divided into 3 different regions: rear foot, midfoot, and forefoot. And that's coming up in the next 2 slides. Okay, so you do have your tarsal bones, which are more on the posterior aspect, the calcaneus or our heel bone, and then just superior to that you have the talus. And next class period, when we get into the ankle, we'll talk about the lower leg, where you have the tibia and the fibula, your weight bearing bone, the lateral bone, and you have your talus kind of in between there. Okay, you have the navicular bone on the medial aspect and the cuboid, and then there's 3 cuneiforms, either called 1, 2, and 3 from medial to lateral, or medial, intermedius, and lateral. You have your 5 metatarsals, metatarsals, because when we start talking about the hand, it's going to be metacarpals. Okay, so the metatarsals are the long bones in your foot, and then you have your toes. Your toes actually have, doing math in my head really quick, which is not good, but your great toe only has a proximal and a distal phalange, and then your digits 2 through 5 have a proximal, middle, and distal phalange. So I'm not going to try and bring my foot up here. I don't have my models at home, but if you were to use your hand, because it's similar, the big toe only has a proximal and a distal phalange, and it only has 1 interphalangeal joint, whereas your other 4 digits, the second toe, third, fourth, and pinky toe, you have a proximal, an intermediate, and a distal phalange. So with that, there are 2 joints, There is the PIP joint, which is the proximal interphalangeal joint, and the DIP joint, distal interphalangeal joint. And so we're not looking at my hand anymore. This is showing you guys actually how it's broken down, where the forefoot is distal and it's the phalanges, midfoot, and then hindfoot, which is the calcaneus and talus. And then getting into a little bit more of the bones. Hopefully this looks familiar. I know we talked about it in PE 108 or Kines 106 since it had changed this past summer. But with looking at the bones in the rear foot, we have the calcaneus, and there are different prominences of it. Those are important because those are different areas in which either tendons or ligaments are attached. And then the talus, which helps us navigate the ankle mortise. Okay, we have the talus. The calcaneus would be distally. The tibia, which is your shin bone or your weight-bearing bone, and then you have your fibula on the lateral aspect. Okay, and just the function of this, because the medial malleolus or malleoli is doesn't go down as long as the lateral malleoli, we are more prone or apt to sustain lateral ankle sprains, and we will get into that at the next class period. So getting into that, midfoot, we are absorbing a lot of the shock, when we are going through our gait pattern. So remember that first photo I showed you as far as the heel strike going through. The midfoot is actually absorbing a lot of the shock, and there is the potential for either the navicular, the cuneiforms, or the cuboid to absorb that. A little bit more of the clinical anatomy. There are sesamoid bones. Usually you'll see them on the great toe or the big toe, right at that MP joint, metatarsal phalangeal joint. There could be, 2 or 3. The 5 metatarsals, I just want to remind you guys that we are counting from first, which is medially, all the way out to our pinky toe, which would be our 5th, okay, more laterally. Looking at, moving this around. Looking at the the dorsal aspect of the foot, we have kind of cut away the skin here. Actually, the plantar fascia is cut so we can see some of those flexors and the abductor hallucis, but this plantar fascia attaches on the calcaneus and goes towards the heads of the metatarsals. You might hear, and we'll talk about a little bit later on, plantar fasciitis, which is an inflammation of the plantar fascia. Pretty painful, and more so in the morning, because overnight your muscles have a chance to cool down, and stereotypically we get up and go. It's not like we warm up or anything. So that's why in the morning it's usually a lot more painful than later on during the day. You guys should remember from the previous class, there are arches of the foot, where we're talking about medial longitudinal arch, lateral longitudinal arch, which is going through the length of the foot, either on the medial side, so closer towards the first metatarsal, or on the lateral aspect, which is by the 5th metatarsal. There is also the transverse arch, and I know before we talked about the metatarsal arch, which is kind of like more the balls of your foot. Plantar fascia, so a couple slides ago, we had the plantar fascia cut. This one is intact, and like I said, it goes from the calcaneus to the heads of the metatarsal. That fascia does get stretched and irritated. A lot of times with plantar fascia, we will have our patients, encourage them to stretch in the morning, or even potentially wear a night splint, which will dorsiflex the foot and kind of keep that taut throughout the night. There are some that are soft, which is kind of like a sock with a strap on the toes to dorsiflex, and it velcros underneath the proximal portion of your calf. And then there are also hard night splints that are similar to a walking boot that sometimes people love, sometimes they hate, sometimes their partners hate because they end up kicking them and getting them bruised. So when the plantar fascia and the medial longitudinal arch, we are potentially worried about the height difference. Maybe you have heard when you gain weight. I know when I was pregnant, I felt a noticeable difference in my shoe size, and not just because I was getting bigger and my ankles were swelling, but because that medial longitudinal arch was dropping and kind of elongating the foot. So that's why, I know on some movies they'll joke about, I've gained 3 shoe sizes. I don't think it's necessarily that much, but it's something to be conscientious of. And this is just looking at the transverse metatarsal arch, again, digits 1 through 5, and how that can affect. Also, when we're walking in our gait pattern, when we're going through mid-stance to kind of toe off, there's getting somewhat of a stretch for that metatarsal arch. So we should be somewhat familiar. You should be able to know all of the bones of the foot. Now we're getting into a little bit more depth of the clinical anatomy, where we're looking at the neurological anatomy. So on the lateral aspect, there is a medial plantar nerve, and there is the tibial nerve and branches that is more on the posterior aspect of the foot. Okay, arteries and veins. These are important because if they are damaged or injured, we're worried about blood flow and getting oxygenated blood to the distal portion of wherever that injury may have occurred. We should have talked about, and you should be somewhat familiar with the arteries, because there is a dorsal pedal artery, which usually is in between the first and second metatarsal, more distally on the foot. And then there's the posterior tibial artery, and kind of self-explanatory. Veins for returning the deoxygenated blood back up to the heart to kind of go through it all again. If we do have an injury in the foot, and even if these arteries and veins aren't damaged, we're worried about the soft tissue. That soft tissue around it could be swollen and could be putting pressure on either the arteries or veins. So could occlude some blood flow, could start making some of our patients talk about how they have poor circulation, or their feet are always cold. So that's something to be conscientious of. Okay, when we're examining foot and toes, we also want to make sure that we're evaluating not only that, but the ankle complex. And then before, as we've talked about the kinetic chain, we need to kind of work our way back up there. So look at the whole lower extremity. Again, trying to remind you guys that we are always comparing bilateral. And then sometimes some of these injuries can stem from the lumbar spine. So if we have a low back issue and lordosis, where that we have that curvature of the lumbar spine, it can put greater strain on the foot and toes. Also, looking at the gait. I know there's been times, more so when I've been at a high school level, but I come to school and students are high-fiving and hopping up and down, in front of the lockers. And then after school, because they didn't realize I was paying attention, they come in limping or having a pimp walk. Oh, I'm not feeling well. I can't play or practice today. It's never really on a game day when that happens. But that's something to be aware of. Okay, now getting into the hops. So we should be somewhat familiar with history. Make sure we're asking, what happened? Have you had an injury before? How long has it been going on? Have you done anything to address it? Has it helped? Has it hindered? And then we want to make sure we identify if it is acute onset or insidious onset, so more chronic or if it's acute. That acute onset, we're worried about bones and either fracture or dislocation, and then also soft tissue trauma, whereas the chronic or insidious onset could potentially be a stress fracture, which we get a lot with high mileage athletes, sometimes gymnasts or dancers. There could be tissue degeneration or just swelling going on in there. One thing specifically with the foot, when we are asking history, I want to make sure we have the athletes or our patients bring in their shoe attire. Okay, so if it's tennis shoes, cleats, whatever the case may be, we want to ask how old they are. If they're super new, maybe they're trying to break it in. If they are a little bit more worn for wear, when you look at them, if on the outside they're shot, it's almost a guarantee that the inside doesn't have all the support that that patient is used to. So we'll ask them about that. If they don't have their shoes with them, have them bring it in with them the next time. And also ask them to guesstimate, how many miles do you think you have on these? And that's really easy for track and cross country, whereas some of the other sports, volleyball, I don't know. I don't run a ton. Believe it or not, you do, but that's a whole nother story. So ask how long they've had them or how many seasons. And is this their sole shoe? Is this the shoe that they're walking around campus on and they're practicing in? Or is this just a practice shoe? Trying to get an idea of how worn it is. And if maybe the inside and the arch support and everything is still working, or if maybe it's kind of shot and it might be time for a new one. Being conscientious, we're at a college. Not everybody has money to go out and purchase shoes or cleats or whatever the case may be. So a potential fix could be getting inserts, and we will get into that in a little bit before I digress too much. I want to keep on time. So asking what their past medical history is. Do they have diabetes, or does diabetes run in their family? Do they have chronic heel pain? Have they ever been diagnosed with gout? And that is usually going to be indicative of usually the first metatarsal phalangeal joint, so the big toe joint, where it's really swollen and inflamed. Although that's not the only thing, but that's stereotypically kind of the first telltale signs of gout. Okay. The other thing to look at is open wounds. So we might need to be talking to and educating our patients on hygiene and care. I know some of our athletes have, they're tired when they're done with practice and they just go and sit. They haven't taken off their shoes and socks, and now they're sitting in sweaty, gross socks that maybe they have blisters. So you run the risk of potentially getting infected. So that's some things that we, sometimes have to talk with our patients about. Still with history, where is the pain? And this is just showing you different areas of where that pain can be. I usually like to ask, point with one finger where the pain is. Ideally, I would love if they just point, it's right there. Usually we get this. So let's try and narrow it down so they can pinpoint that. And then when we begin our palpation, we can go away from the pain and then towards the pain so we can get a really good idea of what's going on. Again, determining if it's acute or insidious. I have talked about shoes. We should talk about distance and duration of the playing surface that they're on. My fear is when we're coming back from this pandemic, when we first start to come back, I don't know if everybody has been working out like they should have, or as hard as they normally would when they have teammates and other people pushing them and the kind of competition that goes on with that. So we are worried about, the shoes, the distance and duration, so we need to progress them into it, especially if we've been sheltering in place or working out on our own. We don't need to just start like, it's day one of game week. We need to progress them. The other thing is, what type of playing surfaces are they on? Have they changed from grass field to turf or dirt or whatever the case may be. We are fortunate that at MJC we got a new track, I think last summer. It might have been 2 summers ago. My years are starting to run into each other. But with that, we're really fortunate because my first couple of years here, that track was shot. It was almost like running on concrete, and it was like everybody who ran on it ended up with shin splints or MTSS, or they were having arch issues. And that was because the surface that they're practicing on. We did get that new surface, and who'd have thunk? Most of that has gone away, and it had nothing to do, some of it had to do with shoes, but it was all dealing with that plane surface. So something to think about. Okay, inspection. With inspection, we want to make sure we're comparing bilateral, and that's really important. Hopefully we can tell the difference in this picture. This picture is in your guys' book. This would be more of a gross deformity where I don't have to get out the measuring tape and measure the girth. I can, obviously tell that this patient's right foot is swollen. I can see that there was an ACE wrap up here, or actually it probably wasn't even an ACE wrap. I would guess that it was probably a sock and just the compression from the sock because there's so much swelling in there. Okay. We want to look at the coloration. Right now, this person is non-weight bearing. I bet you if they're weight bearing, it makes it worse, or their foot's going to kind of flatten out up against that. So look and evaluate them both non-weight bearing and weight bearing. See what their gait pattern is. And then also, like I said before, look at their shoes. What I'm looking at with their shoes is turn the shoe over, look at the wear pattern. One of my children would wear their cowboy boots and always drag their heels. And I should have kept one or at least taken a picture for this specific reason. But that heel is, totally lopsided. And then when she would just go to stand on it, it was almost like one shoe had a high heel and the other one didn't. So look at the wear pattern. Also with inspection, we want to make sure we are observing them, how they walk, both if they happen to be on crutches or without, looking at that gait dysfunction. We also want to look at what type of foot they have. And we'll get a little bit more, actually a lot more into detail on this with pes planus, pes cavus, or a neutral foot. So hopefully you guys remember pes cavus is that really, really high arch. Pes planus is the flat foot. Neutral would be normal. Another thing we look at is calluses and blisters. Be conscientious of if they did just get brand new shoes or if it's the beginning of the season and they're trying to break in their shoes or cleats. That's common, but random in the middle of the season, nothing's changed. We need to delve a little bit deeper and see what's going on. And then also some skin conditions specifically that are with the foot and toes is tinea pedis, and I have pictures of it later on, but basically that's athlete's foot. It's a fungus, and that's one of the things that I was talking about where maybe patients or student athletes don't change their socks frequently. Well, our feet sweat, some more than others, and if we stay in sweaty socks all day and never change, we run the risk of, it's a perfect breeding ground for different bacteria and fungus. So there's that. And then there's corns or plantar warts, which are on the bottom of the foot. All right, so I was talking about different types of foot classification and evaluating it. We want to make sure we're evaluating this in weight bearing, because in non-weight bearing, everybody might seem or appear to have that neutral stance. When we're looking at them in weight bearing, and how I liken it is, imagine they stepped in water and now they're walking around on the concrete. When you're looking at their footprint of that, the wet water, pes planus, you're going to see the whole entire bottom of the foot. The neutral position where you will see the toes and probably half of the foot and the heel. And then the high arch is you'll see the toes, the heel, and really only the lateral aspect of the foot. So these are ways to be able to identify different types of foot classification. I think it looks really cool when sports have team shoes, but it's usually really bad for the athletes because not everybody has the same exact foot type. We might have brands that we prefer because of our foot type and not necessarily because of the looks, or maybe it is because of the brand. But hopefully we have them in cleats and shoes that and track spikes and all the other different footwear that they have, but make sure that their foot attire is comfortable for them. And sometimes, there's been times where we've had teams and we've had to have an exception because somebody had, such a aggravation with the team shoe. Tinea pedis, this is in your guys' book. It's not color, but this is a picture of athlete's foot. You can use different things to help rectify that. I know, there's sprays, there's powders, but educating them on being able to have proper hygiene, changing their socks, not sitting around, will also help. Plantar warts. So a little side note or side story, I had a student athlete his freshman year, and it looked exactly like this on the bottom of his foot, pretty much in the same location. And when we first started noticing it, was a football athlete, and it was probably game 7 or 8, so towards the end of the season, and flat out told him, okay, you really need to address that. There's different things, whether there's the kind of compound W, there's different over-the-counter things that you can try, and when it's small like this, it's great. And I told him, if you're not going to do that, then you need to make sure that you make an appointment with your primary care physician and get that taken care of. Well, life happened. Maybe he thought I didn't know what I was talking. I don't know what the case may be. But he comes back the next year, and I don't have the ability to write, but it was probably, so inside that red circle, it was probably bigger than that red circle. So with a plantar wart, it's not like your traditional wart that maybe you guys see, or we're almost to Halloween time, so where you have you see the witches with that wart. If this were the bottom of my foot, it's still flush with the bottom of my foot. The bigger it gets, it actually grows inside. So when I was at Fresno State, I had an athlete who ended up having to get it surgically removed. And basically what it is it looks like a little baby ice cream scoop, and they have to scoop it out to end up getting it all, and was left with a bigger hole in his foot than was necessary because he waited. It does end up filling in more so with like calluses and scar tissue, but when this athlete came back his sophomore year and it's now grown and he doesn't want to do anything about it because now it's so big, I haven't talked to him after he went on, but I would imagine that it would be really bad. Okay, also make sure we're checking the toes. Okay, this is, I know, not the most pleasant picture, a great picture of ingrown toenails. And a lot of times when people, cut their nails too short, or they might be prone to getting them, there's been times where, people have to go to the doctors to get them removed. Usually what I try and do is get a piece of cotton and shove it underneath the nail bed. That way it will allow the nail to lift up as it's growing out. Another thing you can do is, right here you can tell that they actually kind of cut off the edges. One thing I might do is cut a V in the toe, kind of in the middle of the toenail, and that way it gives the edges a little bit of ability to kind of move inwards and not be pressing on that sensitive skin right there. We're also looking at toe alignment. So Morton's toe is, hopefully you guys remember that, but when the second phalange is longer than the first, and it may not necessarily be the phalange, it may stem from the metatarsal. Then there are claw toes, hammer toes. We are going to end up getting to that, I think, shortly. I also have pictures of a sublingual hematoma, but this is a great picture of an ingrown toenail. Yep, next slide. Sublingual hematoma, it's basically the medical terminology for a blood blister that's underneath a nail. We see it more often with manual laborers, whether it's mechanics or people who work in construction. They accidentally hit the hammer on their nail. It does happen often in sports with the feet because you have cleats. And if maybe somebody's bottom of one of their cleats happens to get you in the right spot, you'll have bleeding under the nail. If the patient comes to me within a day or two, we can lance it, which is basically draining the blood from beneath the nail, depending on where it's at. This one is the whole nail bed, where you might be able to lance it underneath the nail. We also have, disposable cottering pins, where basically it's a hot needle and we're just tapping it on the nail bed. I prefer to tap closer towards the edge of the nail as opposed to more proximally where it's the nail bed, because when it's further away, it takes less time for it to grow out, and that hole won't irritate you, when you have to put on your socks or snag on anything. Okay, when we're inspecting the foot and toes, we want to make sure we're inspecting the medial and lateral aspect. One of the things on the lateral aspect we're worried about, specifically with the fifth metatarsal, is at the base of the fifth, we're worried about an avulsion fracture, because that's where the peroneus brevis attaches. And if you have a severe lateral ankle sprain, sometimes instead of that stretching or tearing, it ends up making it an avulsion fracture. That, and then the medial longitudinal arch, you're going to be able to identify that more with NWB, which is non-weight bearing, and you can identify if they have a high arch or a low arch, pes planus or pes cavus. We want to look both at the dorsal and plantar structure, plantar surfaces of the foot. We're always going to look for swelling, discoloration, any type of abnormalities, and we're comparing bilateral to the uninjured side. We also want to note if there's any blisters or calluses. Those might be indicative of some type of chafing or rubbing, whether it's the shoe or it could be the shoes that they're wearing to school and not their cleats and tennis shoes that they're wearing at practice. We also want to make sure we're identifying and looking at the posterior aspect. This one specifically is looking at the Achilles and looking at what the normal alignment is. I would guess, again, this is in your guys' book, but I would guess that this most likely would be a volleyball athlete, particularly an outside hitter, depending on if they're right or left hand dominant, because they go up and then stereotypically end up landing with more weight on one side, and it ends up giving them more of a prone look on that particular leg. Some more posterior structures. These are retrocalcaneal exostosis. It's basically similar to bursitis. These are going to be painful because anytime you try and wear shoes or cleats, especially with a heel, it's going to rub on that. So usually we would tell them to wear flip-flops or slides to try and give this a little bit of rest. And now we're getting into more of the different types of inspection of the toes. There is claw toe, where it's continuously flexed. There is the hammer toe, where the PIP, proximal interphalangeal joint, is flexed. And then Morton's toe is, like I said, the second digit is longer than the first, and stereotypically that stems from the metatarsal. And then hallux valgus. Hopefully you guys remember valgus from the previous class, but valgus, you've got that L. L means there is lateral pressure, and that lateral pressure is putting stress on that medial aspect. So just like with the foot, there's that lateral pressure, and you can tell right here. There are people, when it gets pretty severe, that they may have to have surgical intervention to rectify this. One of the reasons why this can happen is not having appropriately fitting shoes. The toe boxes could be too small. Maybe they have, instead of like a square toe cowboy boot, maybe it's more like a stiletto shoe, or the pointed boot where it's shoving all the toes kind of squished together in that toe box. So paying attention to that. And that's why I know some people, and I still have athletes who will leave their sock on or leave their sock on their toes. Oh, I've got ugly toes, or I need a pedicure. Sometimes when we're doing an evaluation and an inspection, we need to make sure we're looking at that. And if it makes them feel more comfortable, okay, come in my office or come in an examination room or whatever the case may be. But I want to make sure that I have the full history, full inspection of this before, I can give them proper advice on how to get better. Palpation. So stereotypically, this would be the point in time in which we would break up in pairs and get Sharpies, not Sharpies, but markers, and at least draw where some of these markers are. We can't do that because of virtual. I would highly recommend, not that you have to draw on people, but even at your own foot, with your own foot, take your shoe and sock off, bring your foot up, start looking at it. If you have somebody in your house that you can, look at and palpate, it will help make it easier. And I will admit, I used to hate feet. I hated somebody touching my foot. I hated other people touching my feet. I sprained my ankle playing soccer and had to go get my ankles taped, so I had to get over that. That and then getting an evaluation, you have to get over it. That's how I was introduced to athletic training and how to get over the foot issue. And I have no problem with it now. Yes, I definitely wash my hands after every patient and, move along. But when we're looking here, you've got the metatarsophalangeal joint, and this is looking at the medial aspect. You've got the first metatarsal, you've got your cuneiform, the navicular tuberosity, which is on that most medial point. When you're looking and palpating at on your foot, try and find that navicular tuberosity. We're going to talk about the navicular drop a little bit later on. The calcaneus, all these other things. So go back, look at and identify these bony landmarks so you are able to have a better understanding. This is looking at the lateral aspect. Number 3 is the styloid process of the fifth, and that's what we're worried about with that avulsion fracture. Okay, here on the dorsal structures, we potentially are worried about that inferior extensor retinaculum, where if you are forced into plantar flexion and still going forward, or maybe you get your foot caught in the ground as you're going forward, we are worried about potentially a syndesmotic sprain, which is on that surface. I do want to point out, look at 11. That is where the dorsal pedal pulse is. Okay. And then the plantar surface, where, again, you can palpate the calcaneus, the plantar fascia, and a lot of the flexors. So when we are looking at this and now getting into more of the range of motion, this is looking specifically at the first metatarsophalangeal joint, so basically your big toe. Flexion, you should have about 35 to 45 degrees, and extension is 75 to 80. And again, this is with active range of motion. We would do manual muscle test or resistive range of motion. Again, you have to kind of even it out with your fingers. This particular clinician is doing, each finger on each toe. I know some people will have like their whole finger under their toe. It might not be as fluid, so find out what works for you and stick with that. And then for extension, I would do the big toe individual from the other digits. This I just wanted to include for those that maybe don't have the book. And the different end feels, which we will get into shortly. We're looking specifically for those end feels with different stability tests or special tests. So looking at the foot and toes, Hopefully you guys remember valgus and varus stress test. So valgus, there's that L in there. Valgus stress test is putting lateral pressure and assessing the medial aspect, whereas varus is the exact opposite. Okay. When we're looking at joint play, we are doing glides. So, and I don't even have somebody else, but basically I will get one of the bones and the other bone, and I might shift it back and forth in an anterior posterior glide, and going through all of those. So we're just trying to play and see how much range of motion there is in between, if it elicits pain, and then also make sure you're comparing bilateral. You might often be able to see that there's swelling in that joint, and that will be another indication. Vascular assessment, either capillary refill, looking at the nail bed, dorsal pedal pulse, or the posterior tibial pulse. Okay. Again, now we're getting some better pictures of pes planus, or flat feet. It's where the talus tilts medially and the navicular displaces inferiorly. So right here, hopefully you guys can see my little arrow. I can't palpate, and this is something that I'm having to get better and better at with telehealth. But this right here structure to me looks like the navicular tuberosity. So with that, it's easier, telehealth, whether it's FaceTime or doing a Zoom or whatever the case may be. One, we need to make sure we're HIPAA compliant, but two, you can ask for feedback. Hey, touch this area for me. Does that hurt? Or do you feel a bump? Or, try and have them explain what they're feeling and pointing out where it hurts. Okay, the navicular drop. Let me see if I can... Yeah, it won't let me. I was trying to zoom in. The navicular drop. So this slide is non-weight bearing. So they're sitting in a chair, where, if you guys can tell, there's a black marker right here. That black marker, you put a little 3x5 card next to it. You mark it with a line, because that's even and it's flush with the floor. Now you have them stand up, and there is a drop in the navicular. So we're worried about that medial longitudinal arch. And this is a pretty significant drop. In all honesty, when you have time and everything else, yes, I highly recommend measuring it out so you can tell how it started, how it's progressing. But even just eyeballing, once you're proficient, once you know where the navicular is, sometimes you can just have that dot on that and then have them stand up, and you can kind of see it drop, or you can see the arch kind of make them from kind of a pes cavus or normal down to a pes planus. Oops. So foot structure. This is now going to be a picture more of a high arch, or pes cavus. With this person, they have a high medial longitudinal arch. There is less contact with the ground. They might be more prone to having a lateral ankle sprain because they have all of their weight on that lateral aspect. There can be calluses over the PIP, the proximal interphalangeal joints, of digits 2 through 5. And most likely, if their foot is causing them pain and there wasn't a acute onset, it was insidious, it could be the shoes, but two, it might be worth them getting orthotics. Okay, so one of the things that I recommend for my patients is, if they're having foot or arch issues, let's try taping it and see if that helps. If that helps, it might be worth them going to see if they can get an orthotic. If they have insurance, we can, help work with them getting an appointment with a podiatrist, which is somebody who specializes in foot. If not, or money is a concern, a lot of times I will recommend that they go to either Fleet Feet, or Fleet Feet sometimes is a little bit more expensive. Usually first I would say go to a Walgreens or a Walmart, where they have those Dr. Scholl's like little kiosks where you can stand on there and they'll tell you what kind of foot you have and maybe what type of insert you need. Those are usually a little less expensive. So there's a couple of different things that we can do to kind of help our patients. Okay, plantar fasciitis. So it's the inflammation of the plantar fascia. They're going to have a lot more pain in the morning because of what I talked about before, as far as muscles have a chance to shorten and cool down overnight. And usually we get up and go, go, go. So they will have difficulty putting weight on it. They may feel like they are tearing the bottom of their foot. Sometimes it early on in careers or when you're still figuring things out, it's somewhat easy to confuse plantar fasciitis with a arch strain. And I know I've had some athletes, maybe they were at Great America or Six Flags and walking around all the time and the hills or whatever, and they're like, oh man, the bottom of my foot hurts. It's not always plantar fasciitis. It could be an arch issue. So we want to make sure we're able to palpate and correctly identify what's going on with that. Heel spurs. So hopefully you can see this arrow. There's an additional like bone growth or calcification on the calcaneus. And this is the medial view of the right foot. So it will often present with a hook shape and will be a gradual onset. They will have a lot of pain at the initial heel strike when they're walking. Most of the time, physicians will try and do a conservative treatment, giving them stretching, changing in footwear, or wearing shoes. I've got a bad habit, especially in the summer when I'm home. I walk around all the time barefoot, even out front. Hopefully, knock on wood or whatever, but I have a sneaking suspicion I'll probably have feet issues because not that I don't take care of them, but I walk around barefoot. Okay, tarsal tunnel syndrome. So this is something we didn't really talk about very much, or I think at all, in the prior class. I do know we addressed carpal tunnel syndrome within the wrist. So tarsal tunnel syndrome is very similar, just different body part. Okay, you've got your flexor retinaculum that underneath the nerve goes through. If that's tight, or if there's any type of swelling to these tendons or any structure around there, it could put pressure on that nerve and cause pain. It could cause numbness and tingling. They might feel like a burning sensation. It will definitely increase with activity, decrease with rest. And so most people will say, okay, well, rest it. Well, it's difficult for an athlete to rest it. So, and because it's a lower extremity and we're standing and walking all the time, we might see if we can cross train them, have them on the bike, have them on an elliptical. Actually, I would probably just have them on the bike or in a pool. The elliptical, they're still weight bearing and, potential for irritation. So bike and elliptical would be our best bet. In order to identify if they have tarsal tunnel syndrome, there's what's called Tenniel sign. And again, using our index and middle finger, almost like you were to take a pulse, you're just going to tap on the posterior aspect of that malleoli. If they get numbness and tingling or it elicits pain, it's going to be a positive. Okay, we're almost done, guys, or getting there. We are now talking about metatarsal fractures. Okay, so we're getting a little bit more in depth and in detail. I did talk to you guys in the last class about avulsion fracture. We talked specifically about when we are taping an ankle and leaving that tape right on that base of the fifth, and we give them an increased risk of potentially getting an avulsion fracture because that's where the peroneus brevis attaches. If you go up, if you go down a little bit more distally, that fracture would be called a Jones fracture. And stress fracture, it can happen anywhere, stereotypically on the long bones. I know I have military athletic training friends, or I guess athletic training friends who work in the military setting, let me correct that, that they have a lot of patients, especially during boot camp, that get stress fractures because now this active population, these athletes are running around usually in these boots, may not necessarily have arch support, and it's just repeated stress. And not only the stress of running, but a lot of times they have heavy gear that they're wearing. Okay, so those are other things to think about. This is a x-ray of a Jones fracture. I don't like that it's covering this up. Oh, wow. I can move it, sorry. But looking specifically at that, that's kind of black and white. I don't need to be a radiologist to be able to identify that. I don't pretend to be a radiologist. They're amazing and often have the capabilities of, now that a lot of the stuff has gone digital, they can change the, not aperture, they can change the light. I don't know what I want to say. They can change the going from dark to light to be able to identify this. But this, you don't really need to change anything. It's pretty apparent. Okay, long bone compression test. If we suspect that they have a metatarsal fracture, we would basically kind of a compression test. So think of two linemen, pushing up against each other. That's exactly what we do. In this person's midfoot, she's holding stabilization and she's putting compression in there. So a longitudinal force. They may say it elicits pain. You might feel a false joint, meaning it feels like there's a little bit more movement than what there should be. And again, I'm not going to go straight for that metatarsal that's in pain. I would go further away and then work my way towards it. That way they know what to expect and what it feels like. And then when we actually do it on the one that's injured, they'll be able to have a better indication of what's going on. Okay, getting into Lisfranc fractures or Lisfranc injuries. Can be sprains, dislocations, fractures, or fracture and dislocation, and that is specifically within the tarso-metatarsal joints. Okay, that MOI, mechanism of injury, is usually going to be an axial load on the foot with the toes extended. So a lot of time dancers, ballet, when they're up on point, it's amazing strength, but often they will end up with issues with this. In order to kind of fix this and rectify it, there's some type of kind of a modified Hardcastle system that you guys will learn more so at the 4-year level. And then phalangeal fractures. Usually it's going to be a longitudinal force. Sometimes it happens to be because a cleat has stepped on you. I have little baby feet, and at one point in time or another, all of my toes have been broken. Not all at the same time, but just with the bottom of those cleats, when somebody's full weight is on that and you have these small bones like your phalanges, you have the risk of potentially having a fracture. You're going to have pain. There potentially could be a deformity. They're going to have a pimp walk, or what I talk about as an antalgic gait, where they're limping because they don't want to move their toes. Unfortunately, even if you do have a fracture of the phalanges, specifically of the toe, there's not a whole lot that the hospital or the ER is going to be able to do unless it's displaced and needs x-rays. But for the most part, they're going to take an x-ray. They're going to say, yep, it's fractured. We're going to buddy tape it, meaning we're going to tape it to the toe next to it and try and stay off of it. And then you just have to wait for it to heal. Not pleasant, but, often if it's something where there's a ton of crepitus or I can feel apparent movement, yes, I'll send them in. If not, I'll give them the same spiel that I just gave you guys as far as they'll buddy tape it, they'll give you an x-ray and tell you, but not going to get a whole lot. And then hallux valgus. So there was a picture much earlier, and remember valgus, L, there's a lateral pressure. So basically those that have wear stilettos or pointed shoes are running the risk of with hallux valgus and getting bunions. This is just the table that's in your guys's book. I wanted you guys to have this. Feel free to go back and look at the PowerPoints or pause this to kind of go through and look at it. First, metatarsal phalangeal joint sprains. We learned this in the last class as turf toe. The stereotypical mechanism of injury is going to be repeated hyperextension, and the foot is planted and the ankle is dorsiflexed. So the foot is planted, you might be up on the balls of your feet, and then that big toe is dorsiflexed. You're going to have pain with push-off, not have a ton of range of motion, and be painful when we're kind of planting and twisting. With that, there is a specific tape job, and I believe I have that in a different PowerPoint, which I'm not necessarily going to lecture on when we come back to campus to be able to do some of our hands-on skills. We'll kind of pick and choose what we're doing. In this module for week 4, I do have that PowerPoint in there. So I'd like you guys to at least go and look at it, look at the pictures, and then at a later date when we get closer, we will be able to kind of better identify which skills we're going to kind of pick to focus on. On-field evaluation of the foot, usually they might be non-weight bearing. Some of the knuckleheads will, I don't want you coming out on the field after me, and they're hopping on one leg out to the sidelines. I fear that with them doing that, they might injure the good side. So we do try and have them stop and do a 2-person assist or 2-person carry. But, not everybody, some athletes can be hard-headed. I'm one of them. Also, we're looking at if there is a fracture or dislocation, we're going to splint them and refer them. Equipment considerations. Sometimes we will take the shoe off the field. Other times, especially if it's a foot, depending on their pain tolerance, and I know I don't always have clear-cut answers for you guys because a lot of it seems to be it depends. And I remember as a student, I hated that, so I do note that, but it's very situational, okay? It's not just black and white. We need to take into consideration everything. If they do report a crack or a pop, and that's why I say, did you hear anything? I don't like that question because it's not an open-ended question. I prefer, where they can elaborate more. So instead, I try and remind myself to say, did you hear anything? And that's another one. What did you hear, if anything? If they say there's a crack or a pop, or they feel like their foot's getting wet, stereotypically that's going to be blood, we will take off the shoe, and there is appropriate way to take off the shoe. I will find a video. I thought I had it in here. But there is a video where basically we want to loosen all the shoelaces, open up kind of where we put our foot in as much as possible, slide the heel out, and kind of let it come out of the toes. Or off of the toes. Also, when we have socks, if at all possible, we'll try and stretch them out to kind of pull them off. I remember I had an athlete who dislocated and fractured her ankle, the softball girl that I talk about and have pictures in, and she was irate that we cut her Nike socks. And I knew she worked at Nike, and I was like, girl, I will give you money and buy you a new sock. So sometimes we do have to cut that stuff off. The cleat, I would prefer not to cut off. We might have to cut the laces just to do it fast. But I know on the football sideline, we do have extra laces. But usually if it's something that's that significant, I have a sneaking suspicion that that athlete might not be going back onto the field. On the field history, what we've kind of talked about at length in the last class, get the mechanism of injury, where does it hurt, any sounds, can you walk on it, and radiating pain. Sometimes when we're evaluating and we're talking to them, I will flat out say, okay, whatever ankle, foot it is, don't put any weight on it. Let's use your other side. Go ahead and stand up. You can use my short butt, or, we'll get some teammates to kind of 2-person assist. But even while they're standing there, ask them what their pain is. Maybe they've stood up, maybe they've put a little bit of weight on it and they're like, you know what, it's not that bad. Sometimes they freak themselves out. So pay attention. You may want to do that unless they've heard that pop or snap, or you think that there's a fracture or a dislocation. Then we don't want to have any type of weight bearing. Posture. How is the athlete faced? Are they walking normally? Are they hopping off the field? When we take the shoes off, now we can get a better idea of what's going on, where we're going through our hop and soaps. You know, what is the integrity of the joints, any deformity, swelling. Look for scars too. Sometimes there are scars that might be indicative of a prior surgery, or it could be something as, you know, I tripped over a sprinkler when I was little and cut myself. So ask about those scars, because sometimes they prove to be worthwhile in our findings. On the field palpation, I've told you guys my way of doing it is bony palpation and then soft tissue, because I want to rule out fracture or dislocation. Again, I try and go where it doesn't hurt and then towards where it does hurt. But, you know, I would surmise that a lot of clinicians have their own way or own methods. This is one of the things that I've been taught by several people to do. We can do on the field range of motion tests. We're doing active and passive. Unless I think there's a fracture, I might try and get them off the field to then take the shoe off and get a better range of motion and feel for it. Because when you're on the field doing all of that, all eyes are on you. And sometimes it will exacerbate the athlete. They might start getting anxiety or whatever the case may be. Oh, everybody's looking at me. I know on the sidelines at many four-year institutions, they'll have medical tents, pop-up tents where they'll put it over. That way they can do a thorough evaluation without having to leave too far from the field. And that athlete is not worried about everybody being able to identify what's going on or looking macho or not showing pain. Maybe they're a prospect to go into the pros and they don't want everybody all up in their business. So that's another reason too. On-field management, unless it's rare, usually it doesn't require immediate transport to the hospital. If there is a plantar fascia rupture, you can splint and send them. If it is an Achilles tendon rupture, usually they are going, but stereotypically foot isn't an emergency. And I know it might be an emergency to some, but if you have your ABCs, you're not severely bleeding, you're not going into shock. If you go to the emergency room, you might be there until who knows when. So that's the other reason I try and educate them, or I might steer them in the direction of let's send you to urgent care. One, the copay is not that much. You might get more without having to wait as long. And that's for game or practice situations. For game situations, for football, our team physician's there. Usually he can call ahead and kind of get you in quicker. Or there's been times where, he can send, depending on day and what's going on, I can call or text him and he's like, you know what, I don't have anybody. Let's get them in for an x-ray. And that's usually if I'm on the fence. I love that, where we can get that, almost immediate attention and we're not wasting the athlete's time or clogging up the ER. Last thing on the field management, fractures and dislocations. Okay, we need to, if we suspect a fracture or a dislocation, we're going to remove them from the field. I don't want them putting any weight on that extremity. So we can still do a two-person assist where the individual or the patient uses two different people as crutches, and they're just non-weight bearing NWB on that particular side. We're going to immobilize. We either have a walking boot, we have vacuum splints, we can make a splint. And then also give them crutches. There was one point in time where I was like super low on crutches. Nobody was bringing them back. And then I bought a whole bunch and then people brought them back. So we're good on crutches for a while. I guess I should say not the extra large, not our, 6'5" and up people. I think we only have one of those, so I do need to order more. Provide first aid and then give them a referral. Give them an idea, fractures and dislocations. They're going to have to get x-rays. And, unfortunately, if it's after or outside stereotypical hours, they very well may have to go to the ER. And with that, I am done with Chapter 8, Foot and Toe. I feel free to reach out with any questions, and I will talk to you guys later. Thank you.